Hi everyone, welcome back. Today we're going to be talking about health programs in India, and we're going to start with National Vector Borne Disease Control Program, also known as NVBDCP. So, the first disease we're going to talk about is malaria. So, firstly, there's a short note on the organization of the program in general for all diseases, and then it goes into the specifics about malaria, including the drug distribution centers, fever treatment depots, and the urban malaria scheme, and a national framework for malaria elimination in India with goals and objectives, which was launched in 2016 and expected to be achieved by 2030. And the program is phased into categories 0, 1, 2, and 3 based on API or annual parasite index, which is an epidemiological parameter for malaria. So there are various milestones and targets which were set to be achieved by 2022, 2024, and 2030, along with a special strategy for Plasmodium vivax elimination. In districts, the PHCs are divided into 5 strata based on the malaria caseload, that is 0 cases, and then API from 0 to 1, 1 to 2, 2 to 5, and more than 5 per thousand population. And the program phasing of for states is based on category 0 with having 0 cases. Category 1 has API less than 1. Category 2, the state API is less than 1, but few districts have an API more than 1. And category 3 is when the entire state, all the districts in the state, have an API more than 1. So, in order of increasing intensity, we have particular measures for each category. For category 3, we have intensified control measures. Category 2, pre-elimination measures. For category 1, we have elimination measures. And for category 0, we have prevention of re-establishment. So, surveillance is an important part of contagious diseases, especially vector-borne diseases like this one. So, we need to know the steps of malaria surveillance and the various parameters that we assess in the process, which include API, of course, annual parasite incidence, then the annual blood examination rate, annual falciparum incidence rate, slight positivity rate, and slight falciparum rate. We then move on to deal with sentinel surveillance in malaria, typical management of a malaria case, and integrated vector control measures. We also learn about the malaria paradigms or ecotypes, in which, for example, in tribal areas, the prevalence of falciparum infections is very high. So there's a separate tribal malaria action plan in place to tackle the same. And behavioral change communication is also pretty important. So June is observed as the anti-malarial month by health professionals, and this program is integrated with other programs like IDSP and dengue control, which is anyways under NVBDCP only, and RCH, that is reproductive and child health care. And small note on few achievements, which you can skip if you want. Moving on to our next vector-borne disease, that is lymphatic filariasis. So there are few broad strategies, very common strategies that you can use to tackle filariasis. So we have annual mass drug administrations of single dose diethyl carbamazine plus albendazole FDCs, and home-based lymphedema management, and scaling up of hydrocele operations in identified community health centers or district hospitals or medical colleges. Next up, we have the management of Kala Azar. So, we aim for enhanced case detection with RK39RD kits and vector control measures, communication for behavioral impact, intersectoral coordination to be improved, capacity building of the existing healthcare system, and monitoring, supervision, and evaluation of cases, and enhancing guidelines on prevention and control. Next, we have Japanese encephalitis, which also has similar strategies for management as listed for Kalasa. In addition to that, we have enhanced sentinel surveillance, breeding of larvivorous fishes to control the vector, and outdoor space sprays because indoors residual sprays are not effective in controlling the vector in question, that is the Culex mosquito. Similar strategies apply for dengue as well and chikungunya. Now moving to the next health program, that is National Leprosy Elimination Program. So here we need to know the initiatives of the program, the disability prevention and medical rehabilitation measures, urban services offered for leprosy care, and the 12th 5-year plan period implementation measures, which is clearly in the past now. And we have case detection and management, Spurge leprosy awareness campaigns in villages, survey education and treatment or SET scheme, incentives by district leprosy officers of rupees 12,000 for any major reconstructive surgeries to patients irrespective of their financial status, and we have a small list of the present day strategies to ensure leprosy elimination and a roadmap for the same in the period 2023 to 2027. And there's a small diagram showing the 5 strategic pillars of leprosy elimination. Would be good to know, recommended to remember. Next up, we have one of the most important programs here. That's a National Tuberculosis Elimination Program, which has a roadmap from 2014 to 2034 with a global end TB strategy in place. So in India, we need to know the NTEP organogram and also know the head officers of each strata wherever given. This is a very important diagram. And there's another diagram for TB lab services, CB-NAT sites, and drug-resistant TB centers. You should know that the various tiers of labs and tests available in place. There's also national policy for the diagnosis of TB, and there are various new initiatives taken up, like the Nikshai portal, the concept of TB notification, a total ban on TB serology, and a direct beneficiary transfer system which links patient information with Aadhaar and PEMS via Nikshai. So for the initiation of treatment, you need to know about the concept of DOTS, which is direct observed therapeutic supervision, and a short course chemotherapy which is given free of cost. And the new initiatives for treatment are as follows: a daily pediatric TB regimen, daily TB regimen for all types of TB, pilots for universal access to TB cases, and universal drug susceptibility testing, a shorter regimen and bedaquiline regimen in 2018, and a campaign mode. In 2024, a new TB regimen called the B-PALM regimen was introduced for drug-resistant TB. Now we talk about drug resistance, one of the most in vogue topics of medicine today. So we need to know the surveillance of drug resistance for TB, and then how we manage drug resistance, in which there's a state level structure and responsibilities of different officers, and drug resistant TB centers at the district and nodal levels, which follow a decentralized test and treat approach. There's also short notes on private sector TB care, monitoring of TB cases, what's the TB score, and one important subtopic, that's TB HIV coordination, and the National Strategic Plan for TB Elimination in 2017 to 2025, in which you have objectives, strategies, and expected outcomes. That finishes NTEP. Now moving on to NACP, that's the National AIDS Control Program, which is currently in its 5th phase. We need to know the goals, objectives, strategic interventions for the same. And like NVBDCP, states are classified into Group 1, Group 2, and Group 3 based on HIV prevalence. Group 1 is high, Group 2 is moderate, and Group 3 is low prevalence. Districts are further grouped into Groups A, B, C, D, In Category A districts, the prevalence of antenatal and parent-to-child transmitted HIV cases is more than 1%. And Category B, ANC and PTCT HIV cases are less than 1%, but high-risk group population HIV cases are more than 5%. In Category C, the prevalence of HIV cases in general is less than 1%, and high-risk group cases are less than 5%, while there are known hotspots existing in the area. And Category D districts have less than 1% prevalence, less than 5% HRG HIV cases, and there exist no known hotspots and a poor availability of HIV data. After that, we need to know the basic structure of the National AIDS Control Organization, and then the salient features of HIV surveillance, which include sentinel surveillance, the 5 objectives of sentinel surveillance, zero surveillance, AIDS case surveillance, surveillance of sexually transmitted diseases like in general, other diseases also included, behavioral surveillance, and integration with surveillance of other diseases. We then learn about HIV counseling and testing services, in which we know the broad components are ICTC, PPTCT, that's prevention of parent to child transmission, and HIV TB collaborative activities. An important diagram to know is the various levels of ICTCs. Then we have care, support, and treatment, in which we have to achieve the 95 95 95 target by 2030. Is 95% knowing the status of HIV, and 95% of those who know their HIV status are on ART, and 95% of those on ART should have adequate viral suppression. Now, the various services offered are first line, alternate first line, second line, and third line antiretroviral therapy. Second line is for pediatrics, plus early infant diagnosis as well. And along with that, the follow up and monitoring and management of opportunistic infections like TB, hepatitis B or hepatitis C, Kala Azar, and others, like mainly pneumocystis pneumonia. We also have targeted interventions for high risk groups like the link worker scheme, blood transfusion services, ensuring safe blood transmission basically, promotion of usage of condoms, and Suraksha clinics, that is sexual transmitted infections or reproductive tract infection services, in which you have color coded kits number 1 to 7, which gray kits are for urethral discharge, anorectal discharge, and cervicitis. Green kits are for vaginitis. White kits are for white, blue, red kits are for genital ulcers. Yellow kits are for lower abdominal pain, and black kits are for inguinal buboes. So these are the various sample correction kits available in Suraksha clinics. Now, coming to the next health program in India, that is the National Program for the Control of Blindness. It's very important from an ophthalmology perspective as well. So we need to know the objectives of the program and the various activities that are primary, secondary, and tertiary eye care services, infrastructure development and capacity building of ophthalmology institutes, and research, surveys, and studies. The diagram of the organization structure is a bit important, and Vision 2020 is the right to sight. Next, we have iodine deficiency disease program, in which you need to know the objectives. And next, we move on to the universal immunization program, in which we learn about pulse polio, inactivated polio vaccine, the second opportunity for measles vaccination, pentavac, Japanese encephalitis, rotavirus, rubella, measles rubella vaccination, pneumococcal vaccines, what is Mission Indradhanush, and few frequently asked questions about vaccines. Then we have the National Health Mission, in which we need to know any 5 or to 10 interventions. There's a huge list, so remember like any 5 to 10 of them. And then we have the National Urban Health Mission, in which you need to know the target groups, what is ASHA, and what the services offered by an ASHA worker, and the various components of the program, in which is a separate diagram in itself. And we have referral units and linkages. And the referral units here are urban community health centers and primary health centers. This is an exception for seven metropolitan cities in which it's managed directly through the municipal corporation. Coming to the National Rural Health Mission, it has few plans in place to strengthen infrastructure at the grassroots level in the rural areas, which is very important for developing countries, especially like ours. And on the diagram here as well for the levels of infrastructure and the various initiatives in place like Asha, Rogi Kalyan Samitis, untied grants to sub-centers, village health sanitation and nutrition committees, the JSY and JSSK programs, which we'll discuss in detail later on, the National Mobile Medical Units, and National Ambulance Services. As medical students, we need to know two important helplines. 108 is the standard ambulance helpline for emergency patient transport, and 102 is for basic patient transport. There are also a few new initiatives under this program, like home delivery of contraceptives, ASHA involvement in home based newborn care, the RBSK and RKSK programs, introduction of MCH wings, the RMNCH plus A approach in healthcare, Kilikari, and the Ayushman Bhavat campaign. Coming to the next component, the biggest component of this chapter, reproductive and child healthcare services or RCH. So we have phase one, in which major interventions were dealt with, like essential obstetric care, emergency obstetric care, MTPs, 24-hour delivery services at PHCs and CHCs, reproductive tract infection or sexually transmitted disease control, immunization, essential newborn care, diarrheal disease control, acute respiratory disease control, prevention and control of vitamin A deficiency in kids, and the same thing for anemia, and dye training services. In phase 2, the program further expands upon essential obstetric care, in which it tries to promote institutional delivery and ensure skilled attendance at delivery, and emergency obstetric care, involving the operationalization of first referral units, the operationalization of first referral units, and also of PHCs or CHCs for 24/7 delivery services. So it lists the requirements for a first referral unit as well, in which you need to have availability of surgical interventions, newborn care, adequate facilities for that, and 24/7 blood storage facilities. Next, we deal with various schemes that are part of the maternal health components, starting with JSY or Janani Suraksha Yojana, which principally involves cash assistance. There's a scheme for the same given the textbook. It's a must know. And also other benefits under this scheme, like the Vande Mataram scheme, ensuring safe abortions, carrying out a village health and nutrition day, and reducing maternal death reviews and pregnancy tracking. The next scheme is JSSK or Janani Shishu Suraksha Karyakram. It mainly aims at ensuring free and no expense delivery or C-section for women. Coming to PMSMA or Pradhan Mantri Surakshit Matritva Abhiyan, the services for this scheme are provided on a fixed day, that's the 9th of every month, free of cost, assured and quality antenatal care. Next up, we have Suman or Surakshit Matritva Ashwasan, which aims to provide zero cost, assured quality care and zero tolerance for the denial of services. Next, we have Lakshya, which aims to improve the quality of care in labor rooms and maternity OTs in public health facilities. After that, we also have Anemia Mukt Bharat, and MA or Mother's Absolute Affection Program, which aims to promote the early initiation of breastfeeding within 1 hour of birth and promote and also promote good infant and young child feeding practices like exclusive breastfeeding up to 6 months of age and continuing breastfeeding until 2 years of age with adequate complementary feeding. And lastly, we have the midwifery initiative. These are the maternal health components of RCH. So now we move on to the child health components of RCH, starting with nutritional rehabilitation centers. These are a very key part of child health component, and we have various services like 24-hour care and monitoring and therapeutic feeding, treatment of complications if any, sensory stimulation and emotional care, which is equally important, counseling on appropriate feeding, care and hygiene to the parents, demonstration and practice by doing on preparation of locally available energy dense foods. Then we have social assessment of the family and of course follow up services to ensure proper growth of the child after discharge from the nutritional rehabilitation center. Then we have management of malnourished kids, like including that includes triage, history and taking an clinical assessment, hospital-based management of severe acute malnutrition, which has 3 phases: stabilization, transition, and rehabilitation phases, micronutrient supplementation of vitamin A, iron, folate, zinc, copper, and other multivitamins, and then of course follow-up services. Next we have IMNCI, the Integrated Management of Neonatal and Child Illnesses, one of the staples of pediatrics, I should say. So firstly we have pre-service facility-based IMNCI, and then we have facility-based newborn care. Then we have newborn care corners and newborn stabilization units and special newborn care units, and the triage of sick newborns, which include the criteria for admission to newborn stabilization units and special newborn care units, and then transfer from SNCU to step down facilities and discharge. Next, we have home based newborn care and the role of ASHA in implementation of the same, and also home based care for a young child, that's HBYC, along with strengthening facility based pediatric care. So the pre-service facility-based IMNCI has like a algorithm which is good to know. Like it's a diagram in the textbook. And we have NSSK, Navjat Shishu Suraksha Karyakram, which concentrates on training healthcare personnel for newborn resuscitation. Another important diagram to note is that for the integrated case management process. And then next we have RBSK, or Rashtriya Bal Swasthya Karyakram, in which revolves around child health screening and early intervention services. For newborns, it aims to improve public health facilities and ensure more regular ASHA home visits. For kids between 6 weeks to 6 years, Anganwadis are the go-to places. And 6 years to 18 years, a government or government-aided school-based screening for any of the 4Ds mentioned above, that is developmental delays, deficiencies, diseases of childhood, and defects at birth. Now, coming to the next program, that's RMNCH plus A, that is reproductive maternal neonatal child healthcare plus adolescents. So, the broad goals and targets are to decrease the infant mortality rate to 25 per 1000 population, decrease the maternal mortality rate to 100 per 100,000 population, and decrease the total fertility rate to 2.1 by 2017. And next we have the adolescent health program, in which we have priority interventions for nutrition by iron and folate acid supplementation, then adolescent reproductive and sexual health service clinics or ARSH clinics, information and counseling on ARSH, menstrual hygiene scheme, and preventive health checkups. So it also deals with care during pregnancy and childbirth and newborn and child care. However, most services are already in place under RCH or National Rural Health Mission. So, and of course, care through the reproductive years is also dealt with, along with small notes on delivery points, MCH wings in hospitals, that's maternal and child healthcare wings in hospitals, and a scorecard, which can be either by a health information management system based dashboard monitoring, or it can be survey based. So lastly, we have RMNCAH plus N, in which the first N stands for newborn and the additional N stands for nutrition. Next, we have the India Newborn Action Plan, in which we have strategic intervention packages for the preconceptional and antenatal care, labor and childbirth care, immediate newborn care, care of a healthy newborn, care of a small and sick newborn, and care beyond newborn survival. So the services are broadly categorized into three categories: ESA, that is E for essential, S for situational, and A for advanced. All this time we dealt with the young spectrum of the population. So now let's move to the other extreme. National Program for Health Care of the Elderly, which aims to provide separate, specialized, comprehensive health care to senior citizens at various levels in the system. So, to ensure the same, we have departments of geriatrics at 20 super specialized institutions, which also include the facility for MD or DNB geriatric medicine, geriatric units at district healthcare centers, rehabilitation units at community health centers in identified districts, activities at PHCs in the identified districts, and activities at subcenters also under the same identified districts. Next, we have NPCDCS, National Program for the Prevention of Cancer, Diabetes, and Cardiovascular Diseases. So the DCS component, that's for diabetes, cardiovascular diseases, and stroke. So we have we need to know the various activities at the subcenter, PHC, district, and urban health checkups and schemes, along with the guidelines for referral and treatment to the various centers and new initiatives undertaken. For the cancer component, we have objectives, that's primary, secondary, and tertiary prevention, and the various schemes under the same, like the establishment of regional cancer centers, oncology wing development, decentralized NGOs, IEC, that's information, education, and communication activities at the central level, and research and training, of course. Then we have the National Tobacco Control Program, the National Mental Health Program, which has few objectives, strategies, and a short note on a district mental health program. Also, the Mental Health Care Act that was passed in 2017. Then we have the Integrated Disease Surveillance Project, plus how to deal with outbreaks. And then we have the Ayushman Bharat. This is a very frequently asked question. It's a must know. Then we have in which we broadly deal with Ayushman Arogya Mandirs, which are basically the new name of Health and Wellness Centers or HWCs, and the Ayushman Bharat PMJAY, the Pradhan Mantri Jan Arogya Yojana scheme, which is being made use of by many patients all across the country. So next we have the NPPMTBI, which deals with trauma and burn injuries. The National Guinea Worm Eradication Program, and then a program to deal with yaws, and then a national program for the control and treatment of occupational diseases, and then nutritional programs which are dealt with in more detail in the separate chapter called nutrition, and then national family welfare program and nutritional family health surveys, which is in the chapter demography and family planning, and then national water supply and sanitation program, in which you have the Swajal Dhara, Bharat Nirman, Nal Jal Yojana, Nirmal Bharat Abhiyan, which are all for rural areas, and the Swachh Bharat Abhiyan for both urban and rural areas. Swajal Dhara has two components. The first Dhara for the block or tehsil level, and the second Dhara for the district level. Then you have the Pradhan Mantri Awas Yojana, as the housing for the urban poor, and then the minimum needs program, which has the following components: rural health, rural water supply, rural electrification, elementary education, adult education, nutrition, environmental improvement of urban slums, and houses for landless laborers. And then to finish, we have the 20-point program, which has a list of 20 points to deal with in improving the quality of life and removing social economic disparities and improving productivity. So that brings us to an end of this huge chapter in community medicine, and hope this was helpful. Thanks for watching. Stay tuned for more.